Collaboration is not just a nice to have, it is our most effective response. So today is a moment for honest, practical conversation about what works, what doesn't, and what it takes to turn a promising concept, tools, and apps into real-world impact. This day of exchange has been made possible by the work of the Geneva Digital Health Hub, the GDHub, and its many partners. The hub, which has been co-founded by the Geneva University and the SDC I'm representing today, back in 2021, plays a key role in creating trust. So again, we are speaking here about trust, neutral spaces where a variety of stakeholders ranging from global institutions, normative institutions like WHO, to local innovators can collaborate. This reflects very much Switzerland's long-standing commitment to inclusive dialogue, cooperation, and responsible innovation in global health. An example of this collaboration, collaborative spirit is the new Digital Health Atlas in the Implementome, a joint effort by, again, WHO, the GDHub, the Pierre Fabre Foundation, the SDC, and many others. You will hear more about this important tool and its brand new AI assistant later in the session. So this afternoon, we will explore a variety of perspectives ranging from science and policy to frontline implementation and innovation. We will explore topics ranging from the digital determinants of health, again, the determinants, and youth mental health, to the critical role of financing and sustainability in scaling solutions at the country and at global level. So these conversations serve as a reminder of a fundamental truth. No matter how advanced a technology is, its success hinges on policy alignment, local ownership, and a long-term approach and financial viability, of course. So it is a pleasure to be here representing the SDC, the Swiss government. I want to sincerely thank the partners of GDHub for co-creating this day, WHO, the Pierre Fabre Foundation, the Geneva Health Forum, of course, the Center for Digital Health and Innovation at Johns Hopkins, the European Space Agency, AI for Life by Artifact, Health Enabled, and many others. So let today be a space not only for exchanging ideas, but for building the relationships and trust, again, that allow those ideas to take root. I wish us all an insightful, productive, and forward-looking session. I thank you. Okay.
Thank you, Erika. That was fantastic and a great start to the session. Now I have the pleasure and privilege to welcome Professor Alan Labreck, Director of the Department of Digital Health and Innovation at the World Health Organization. A leading voice in digital health, Professor Labreck brings over 2 decades of field experience that continues to shape global strategies and investments, especially in low and middle income countries. Please join me in welcoming Professor Labreck. Shagatam.
Swagatam indeed. So one person in the room I can speak Bengali to. So if there are others, I welcome you to join us. But such a privilege to be here, and thank you, Erika, and thanks to SDC for supporting this excellent work. I think back to the days when the thing that you will see later today, known as the Implementome, was a drawing on the back of a napkin. And we never imagined that it would grow to this. We were at that time, we were thinking of it as an atlas of what work was being done in the digital health space. And today we have this amazing tool that is powered by AI. So thank you for that support. So it's an honor to share a few remarks to this session that really focuses on 2 critical components for sustainable digital health transformation: implementation science and policy. With this morning's opening, let me just take a quick show of hands. How many of you were here at the morning opening on the exemplars work? Oh, good, good, good. So there's a good number of you. And for those of you who see the people whose hands are raised, they can catch you up on the really excellent content that we covered in the morning. But what you've seen with that exemplar's work is that digital transformation isn't an overnight process. In many cases, it's the slow and sometimes serendipitous collection of successes and failures. And this afternoon, we're going to have a fail fest to actually celebrate and learn from some of the failures that, that contribute to advancements. And that's really critical. But I think what we hope to achieve is for future countries that are embarking on this journey, that they don't start from zero, and that they can learn from and even adopt or adapt policies, roadmaps, and systems that have worked in similar settings. In 2025, there is no longer patience, nor is there budget to reinvent the wheel. It's why knowledge sharing and partnerships like you heard of today, we can go to a blank screen. I don't think we have to subject this audience to a giant head of mine. Mine's already big enough. But it's why sharing and partnerships between academia, private sector, and civil society help to drive better returns on investment that get us one step closer to more equitable and people-centered digital health systems. You're going to hear today from some champions of people-centeredness, and you'll see what I mean in just a moment. It's also why implementation research is so critical to moving forward faster with more efficient use of resources. We no longer have that luxury for unguided experimentation, where we're barreling forward just because there's a large budget to support this experimentation, but we have to be supporting national goals. So we're working closely with groups like UNICEF to develop broad implementation research strategies and learn from and integrate the lessons into our formal guidance. Today, we have 129 of our 194 countries who have clearly articulated digital health strategies. But strategies aren't enough. So we're seeing countries like Kenya, Indonesia, Malaysia, investing in digital transformation agencies or offices who are given the mandate, the budget, and the authority to develop and steward, to be the custodians of national digital transformation. They ensure interoperability. They serve as the custodians of digital public infrastructure, those roads and highways on which the cars of innovation can run faster. Is this a first step for everyone, investing in a digital transformation office? I don't know. I'm not sure. And this is why we need strong implementation research to study those models and learn from them. I'll give you another example. The Global Digital Health Certification Network, something that WHO began serving as the custodian of in 2023, is digital public infrastructure that supports 82 countries and in the secure exchange of verifiable health credentials. For those of you who recall the pandemic and lived in a country that was able to issue personal health records or COVID vaccine cards and certificates, that was enabled by a background series of technical capacity that allowed countries across border to verify the authenticity of that credential. So we thought to ourselves, how can we repurpose this outside of emergencies for routine healthcare delivery? So last year with Indonesia, Malaysia, and Oman, thanks to that digital infrastructure that those countries had, we were able to enable those countries to issue 250,000 personal health records to pilgrims going on the Hajj, the pilgrimage to Mecca, carrying with them their digital health record. We're also now, as of today, I'm delighted to report about 46 minutes ago, the IHR implementation of the new IHR, the International Health Regulation amendments, was passed by the World Health Assembly. Another landmark that opens up the door for digital yellow cards. How many of you carry with you when you travel around the world, not one, but two, and maybe even three? I'm looking at you, Ilona. You must have several of these yellow cards, because I know I have 5. because each time I go looking for it, I forget where I put it the last time, and then I get another one issued. So imagine that now being at the palm of your hands in your phone as a verifiable credential. Across the region of the Americas, all 21 countries that are participating in this thing called LACPASS, the Pan-American Highway for Digital Health, are able to now share personal health records across these borders thanks to this infrastructure. So we have to keep learning about how maturity of governance, the ability to select and enforce standards, very, very critical, and to curate a wide ecosystem of actors, because none of this is going to be solved just by the public sector alone. It means coordination between the public sector, the private sector, NGOs, and other implementers in this space. But most important, when I look at that second example of the Trust Network, why it has been able to scale so rapidly and engage 82 of our member states is because of one thing, and that is the perception of value, the actual value to people that this digital health and this digital infrastructure gives to drive adoption. And it's the perception of value in political arena, as well as perception of value by the people who have to accept and use that technology. So I want to take us now to the State of Digital Health report that Health Enabled, one of our partners, in support of the Global Initiative on Digital Health, and WHO, published to look at the landscape of the countries captured in the Global Digital Health Monitor. And what is the guidance that we can derive from that corpus of information for implementation research and policy? So there are 7 priorities. The first is investigating sustainable financing models. There is nothing more important than we've learned after the collapse in 41 countries of essential digital systems over the last 3 months than the need for sustainable and local financing models for digital health. We need to strengthen workforce readiness and career pathways. Only 65% of the countries in the monitor, 65% of countries in the monitor are at the lowest phase of maturity when it comes to digital health workforce development. So we have to figure out how to integrate digital health into in-service and pre-service training, especially for women who form the bulk of the workforce in low and middle income countries. WHO is working on a competency framework to ensure that governments have a roadmap to build that capacity in our member states. The third is evaluating governance structures. When I met with the ministers of the Commonwealth a few days ago, they asked the one question: where do we start? And the answer to that question, I believe, is governance. So there isn't one silver bullet solution of governance that will solve every situation, but that approach, the different templates, the examples of what has and hasn't worked for governance in the digital space need to be captured and documented for our member states. The fourth is assessing the impact of investments in interoperability and digital public infrastructure. For 20 years, we've managed to secure financing for digital experiments, for digital shiny objects. But what is difficult to convince donors is to invest in those roads and highways, to invest in the things that will last beyond the period of the project. And I think that's something that we need to continue researching and understanding. Sixth is tracking AI readiness and ethical use frameworks. Nearly half of the countries we have polled are unprepared for emerging technologies like AI, and they also lack clear governance. If you come and ask me, why hasn't digital health scaled? In many places, it's because the fertility of the soil in which the seed of innovation was planted was not ready to accept that innovation. And that fertility is hinged on having good governance and regulatory pathways that can intake innovation and offer it a pathway to scale. I'll leave you with 5 thoughts for implementation. Studying models of governance that enable coordinated national implementation is a critical area of research. The second is strategies for institutionalization, as I just said, taking innovation and moving it into an accelerated pathway to scale up. The third is doing the research to understand what are the barriers to uptake of digital technologies. We're moving from analog systems to digital systems in much of the global health workforce. We cannot assume that that intake or that uptake is going to be automatic with open hearts and minds. We have to understand where and why there may be points of resistance to this new era of increased transparency and potential oversight, and make the case for these new technologies as enablers, as supporters of those health workers who are out there in the field. I think the last and most important point I will leave you with is the importance of mapping the determinants of gender responsive digital health. Because if we do not move forward with equity at the center, and we've had several sessions over the last 2 days on digital rights and digital equity, we will end up leaving people behind as we move forward with these new technologies and innovations. We have to make sure we engage youth. We have to make sure we engage non-digital natives. And I'm looking to see how much gray there is in the room, because I know, like some of you out there, Google didn't exist. It existed shortly after I was born, but not immediately. And so, you know, as non-digital natives, we have to appreciate that there are millions and millions of people for whom technology isn't something they have always lived with. I'm delighted to have a distinguished colleague and friend, Ilona Kickbush, with us here, who has been a champion of this topic, has launched the efforts of the Digital Transformation Labs, and led the Lancet and Financial Times commission of growing up in a digital world to really understand both ends of that spectrum and the perspectives of those who could be left behind. So the one thing I'll leave you with is a reminder that despite all of this progress that we've made in the last 20 years, the lessons that we've learned. I said this in the morning, so I apologize to those of you who heard me say it in the morning. But for those of you who weren't there this morning, in the last 3 months, at least 41 countries, 41 of our 194 member states, have experienced a catastrophic collapse of digital systems and of data continuity. Electronic health records, laboratory information systems, population health registries that held those vital pieces of information that serve as a conduit to better care and saving lives. And the fact that that happened is a wake-up call for all of us, that we were not following the principles that we all agreed to a decade ago to make sure that we would build equitable, local, empowering digital systems. So let's learn from these. Let's use implementation research to strengthen what we do going forward. I'm really looking forward to this conversation. Thank you.
Thank you very much, Alain. It's a real pleasure to have you today to start this session. And thank you for sharing this important reminder. So now we're going to move to the short presentation, the solution pitch. So it's my pleasure to welcome Marie Cutter. She's an app maker and founder of UnityP, and she will present TribeCheck. Thank you, Marie.
Hi, everyone. My name is Marie. I'm a lecturer and I'm an app maker. And I am passionate about making apps that help people. Today, I'm going to introduce TribeCheck mobile application. A few years ago, I was traveling to Sudan, and unfortunately, I caught COVID on the plane. So I ended up confined, alone in an apartment in Khartoum for 10 days. And this is the kind of messages I would exchange with my doctor there. 3 times a day, she would ask me how I was doing and my temperature, my BPM, and oxygen level. when I got back home and recovered, I realized that my case was far from isolated. In Switzerland, for example, over 36% of households have only one person. And that climbs up to over 50% in Sweden or 35% in South Korea. That's millions of people without a safety net, without someone living with them able to detect if something's going wrong and assist them. TribeCheck is that safety net for people living or traveling alone. It's a personal safety mobile application that calls for help when you can't. And it does so by letting you plan ahead what happens if something happens to you. Here's how it works. You schedule a check-in for example, 6 p.m. tonight. At 6 p.m., you'll receive a notification asking how you're doing. If you answer all is good, then the check-in is archived and no one will know about it. But if you miss the check-in, so you don't answer, or you hit the I need help button, then your loved ones will receive an alert with useful information to assist you. What makes TribeCheck different is privacy. We don't store or collect your phone number, your email address. We don't know who you are. It's proactive. So you schedule a check-in when you're feeling vulnerable. And it's only if necessary. So your loved ones will only receive useful information if something happens to you. Otherwise, they won't know that you were feeling vulnerable at that time. I'm very excited to start working on a new core feature on TribeCheck, which is called medical follow-up. And that's where I need you today. You can already prescribe or advise TribeCheck to an at-risk patient going home alone. It's available on both stores for Android and iOS, and you can already download it. With medical follow-up, you'll be able to set up check-in templates, what information to ask and how frequently to ask, replacing my messages on WhatsApp with my doctor. You'll also be able to decide to receive alerts or not. Again, on an only if necessary basis, so you won't be receiving any alerts if everything's fine. And finally, you'll be able to get in touch with the patient's loved ones through the message board. As I said, I'm very excited to start working on this new feature, and I'm inviting you to join me for that. I'm looking for partners, I'm looking for beta testers, I'm looking for health practitioners to better understand the needs, the different contexts around the world, and make sure that TribeCheck is useful as possible to patients and to doctors. If that sounds interesting to you, let's connect on LinkedIn to continue this conversation. Thank you very much for being here today. Thank you very much for listening to me, and enjoy your afternoon.
Thank you very much, Marie, for this presentation. Next in our solution pitch series, we are pleased to welcome Tigest Amrat on stage, scientist at the World Health Organization. Tigest is a global health researcher working on the use of digital technologies, including artificial intelligence, to advance sexual and reproductive health and rights. And today she will be sharing insight about the informal use of mobile phone by healthcare workers to address critical gaps in health systems. Welcome, Tigest.
Thank you. Thank you very much. And it's an honor to be on this session with such esteemed panelists. So just kind of picking up from the previous presenter about this organic use of WhatsApp and informal use of mobile phones. This is an initiative that was initiated by the University of the Western Norway and Johns Hopkins University and the NIPH. And can I control the slides myself? Okay, great. So one of the recognitions that we had was that health workers are using their mobile phones informally to plug gaps in the health system. So all of us, when we need to contact a patient or contact another health worker, what was happening was that we identified that a lot of health workers were actually using their own devices in ways that may not be standardized, regulated, or officially endorsed. And this has both its merits and its disadvantages. Oftentimes, they have to use their own airtime, there's no compensation, and there's no formal guidance on storing data. And this is kind of different from when you're actually given a work phone and it's told, okay, you can use it for official purposes. So we started exploring what are the implications of this. And so some of the possible advantages that we saw was that it could actually increase efficiencies. These are natural ways that health workers are using their mobile devices. It's not something you have to train, build capacity, and a lot of the challenges that we see in top-down digital health interventions and programming. And really, it was helping to support communication between patients. I think we saw a really great example right before, and being able to be connected to their clients, and potentially also keep sensitive information out of the formal system. So potentially working with, populations that have maybe potentially sensitive needs. But at the same time, we also observed that there's potential challenges. There's the boundaries between what's actually happening on the health worker's phone and their work life. This could also, in turn, undermine the patient privacy and confidentiality. I personally was once with a doctor here in Switzerland that just took a photo on their own camera of my lab results, and I wasn't sure where that was going to end up one day. There's legal implications as well. So are people working overtime? And what happens with that information that is being, that is not formally shared and stored? So this was something that we've been thinking about. And with my colleagues that have been working on this, we've been trying to think about how can we harness the good parts, the benefits. There's a lot of great advantages to this, but also minimize the potential harms that could come from everybody just doing things in a very non-standardized and potentially informal way. So these are some of the suggestions that have come up through extensive implementation research and doing evidence syntheses. Adapting existing digital tools so that it could actually capture information that health workers really need. And I think this really gets to the heart of what we call user-centered design. So really being able to do that in a way that kind of mimics things that they would have wanted to do anyway. Being able to provide the appropriate security infrastructure. So if there are mechanisms for protecting patient data, training health workers to use available information, informal communication, such as if they're using their own phones in a more appropriate and secure way. So we just wanted to put this out there, but for more information, I really urge you to take a photo if you need to, but contact my colleagues, Claire Glenton and Simon Lewin. They're really looking forward to more ideas and exploration into how we can actually harness all these insights from the informal mHealth space. So thank you.
Thank you, Tejas. You quickly went through some implementation issues. Great. Thank you for that. Next, I have the privilege to welcome Aisha Binaish, Digital Health Rehabilitation Specialist at the International Committee of Red Cross. Today, she will present on the Digital Center Management System, a solution designed to enhance rehabilitation services for health service users. Welcome, Aisha.
Thank you, Alun. Good afternoon, everyone. I'm Aisha. Thanks for introducing me, and thanks for this opportunity to present the project with this great panel. I'm a physiotherapist working for the ICRC, International Committee Red Cross, for the last 15 years in the humanitarian sector. And I would like to present our digital solution for these physical rehabilitations. So, meet Harun from Kabul, a young teenager who lost both legs and his right hands to a landmine in 2022. After a lengthy rehabilitation journey, he could finally walk again with his new prosthesis in 2024. This 2 years wait exposed a broader crisis. In humanitarian complex setting, clinics still run on paper. Stock are tracked by hand on extensive digital Excel documents, and overworked clinicians struggle with clinical decision due to the lack of access to data. Tracking each user's record is time-consuming, making the planning of the right services at the right moment almost impossible, which impact the people with physical disability and also everyone who needs an assistive technology, the newly injured, people who are in need. Those devices cannot be provided always on the time, and many people do not get the service when they need it. How big it is? 2.4 billion of people worldwide need rehabilitation, and only 1 in 10 received it. And every day that passes widens the gap. So the SCRC developed a technology to respond to these needs. It is an open source platform digitalizing the rehabilitation centers in this particular context where the SCRC work in this conflict and post-conflict area. So the digital center management system is composed by an open MRS, electrical medical record, who will allow the data entry at the point of care when the clinicians meet with the health service users. And this electronic medical record is synchronized with another software called Odoo. Odoo is a stock management system supporting the clinicians also to do stock inventory, manufacturing of prosthetics and orthotics for the orthoprosthetic clinicians. And we do have also an appointment systems and professional dashboard leading also to data visualizations, thanks to the use of the superset applications and also leading to the data indicators monitoring with AHS2. So as you can see, the landing dashboards that are allowing for physical and technical documentation supporting physiotherapists, orthoprosthetics, social workers, and administrators to work on respond to the needs and providing services to the people with physical disability. So today, we deliver and deploy in many contexts. Here you can see, for example, in Gaza, despite the ongoing situations, our colleagues who are able to track and follow the service are needs, like the little Always, who is a spina bifida, who will need to have a renewal of his orthotic device due to this disability. In Goma, another story where we have our colleagues. Teddy, who is an administrator and accountant, who will be able to monitor the activities and related costs that also are being for service deliveries, where he's also interviewing a young patients. And another story as well now in Pakistan, where you can see a person who, with an amputations, had to travel for 24 hours on his motorbike to reach the centers. But he received rapidly his device, his prosthesis, because thanks to the digitalization of the system, he didn't have to wait for his prosthesis. The clinicians were ready to welcome him. So now today, we deploy in 40 centers in 10 countries. We recently deployed in Syria, despite the situations that happened recently, where also in Afghanistan is ongoing for 250,000 users. Today we have more than 36,000 users registered in the system with zero data loss, enabling the clinicians to make their decisions based on the data and to be able to improve their services. So the next Harun will receive more rapidly his next prosthesis and to build a digital confidence leading to a better digital health outcome for our service users. Thank you.
Thank you. Just on time. Thank you so much. So now we are very pleased and honored to welcome Professor Ilona Kilbush, Director of DTH Lab, Digital Transformations for Health Lab. She's a leading expert in global health governance, and she will speak about digital determinants of health. Thank you, Professor.
Thank you very much. Well, I've partly been introduced by Alain, so I don't need to say so much. But I did just want to say that the work that I'm presenting to you is part of a larger project that follows on from the Lancet Commission, which Alain mentioned. And our Digital Health Lab is also looking at a range of different elements. We are obviously looking at governance, and here we're particularly looking at data solidarity. We're working on digital first health systems, and here for 4 years we've worked together with young people all around the world, asking them what their priorities for such a system would be. And we are now bringing this together into a roadmap for digital first health systems. We're also working with young people at the Council of Europe to conceptualize and make very clear what they understand in terms of digital citizenship for health. And the issue of rights, of course, is absolutely central there. And then we work on the digital determinants of young people's health and well-being. And here, because of the many issues that have emerged, there is a strong focus on mental health in the widest sense of the word. So our work is always focusing on young people and working with young people. That's absolutely essential. And if you're interested, Whitney Gray is here, who manages our initiatives with young people, and she can tell you more about that. And our focus is public health. What we've heard so far, these really exciting and fascinating projects and initiatives, at least what I've heard this afternoon, are very health sector, health system related, and that's really important. But our project comes out of the tradition of health promotion and public health, and that's also where we look at how does this work? No, that's back. Okay, let's go forward. Yes. So our starting point is that we look at the digital not as a tool. We look at the digital as a world. We look at it as an environment that shapes people's everyday life, and particularly young people's everyday life. And we're not trying to construct a great difference between the real world and the digital world, because as young people tell us, for them, they're both real worlds. And therefore, it's very important to see in what way this new world is influencing health in both positive and negative ways. And as many of you know, there is an increasing concern about negative health impacts, aside from all the positive things that are there for young people: communication, access to information, and so many other things. We're working on a definition of the digital determinants of health, and we're just engaged in a Lancet series that is going to take that forward with colleagues from all over the world. And I might add here that the DTH Lab is a consortium with colleagues in India, Nigeria, and Canada, aside from us working here. So we see very big new challenges for public health and health promotion, and we work on those: the unequal access to quality digital health solutions in the field of health promotion and prevention. For example, so many young people would need support in terms of their mental health, and they do not have it. It's not a priority. It's not easily accessible enough. We address the growing evidence of digital harms. And here also we tend to, there's this mental health focus, but there are obviously impacts on physical health if people don't move, if they don't sleep, etc. But increasingly we have evidence of brain development damage. And particularly for very young children, we are seeing that this is harming the way their brain is shaped and the way it develops, and we need to be seriously concerned about that. We also deal with the commercial interests. Many of you know there's an area of public health that speaks of the commercial determinants of health. WHO has also just issued a big report on this. And we look at the interface of the digital platforms, the harm to young people's health, and the commercial interests. And of course, one of the things that we really have to grapple with, which is difficult for public health in any arena, but in the arena of AI and digital innovations, we see that, you know, the technology, the innovation, everything that comes with it is rapidly outpacing the policy responses. So you can see here, I've just summarized some of the issues that are at stake here. And we see here one of the things that, you know, brain research, for example, that's so incredibly important for our mental health, is actually being abused to be used to build algorithms that keep children and young people in the digital world in terms of novelty seeking, emotion regulation, and other issues. And of course, and that is at the background of the discussion around, you know, age limits in terms of access to digital platforms, is that adolescence is a time where so many of these things are shaped. And therefore, it is also part of the precautionary principle of public health that we need to address them. We've summarized here, and I'm sure you'll have access to the slides, a range of evidence, and we do have more and more evidence both on the harm and on the positive effects of young people's health. And if you go to our website, you will find a lot of literature that we have compiled and taken forward. And of course, as always, more research is required. And we feel that particularly more research is required on those policy initiatives that countries are now taking to restrict digital access for children and young people. I've mentioned the precautionary principle, and we see with the growing figures of mental health, worsening mental health of young people all around the world, that action needs to be taken. As I've said, we feel that public health must be at the table in shaping new policies and laws to tackle digital determinants. Public health is an arena of regulation as much as of programs to promote health and prevent disease. And we see that a whole range of countries is beginning to frame digital technology use as a public health issue. At the same time, we see that ministries of health and public health agencies have very limited involvement on average in new initiatives that actually take on these issues. We've done a survey of policy initiatives around the world. Again, you can access it on our website. And we see the same tendency as with many other public health issues, be it tobacco, be it alcohol, any type of addiction, eating, moving, whatever. There's a tendency to put the responsibility back on the families, on the parents, and on the users in so many ways, and to focus on just single interventions, even though in public health, what you always have to do is you have to group interventions and see that the dynamics of interventions comes together. And right now we are in a situation that many of the public health strategies that have been applied to other areas, particularly tobacco, and the Surgeon General's report from the United States, when there was still another United States, that was issued then, compared the digital impact and the approaches needed very much along the lines of tobacco, meaning that we need to create safe environments, we need to have age limits, we need to promote different forms of digital and health literacy that come together, and obviously increase the accountability of the tech companies, which is proving incredibly difficult. We've been very lucky that together with the WHO European office, we've been able to be involved with the presidency, the Polish presidency of the European Union, to develop policy recommendations in terms of what a public health agency should be doing. And you can see on this slide here some of the other initiatives that are on a way. We also working with the OECD. They've just issued this very new report that you can see here. So I would recommend to you to look at these reports, to look at the policy recommendations, to look at the overview of the kind of policies that are being developed. These are the priority policy actions that are now being put forward in this joint document that will be launched any day now by WHO Europe, the Polish presidency, and ourselves on the policy priorities for young people. And as you will see in the document, then there are examples and suggestions from such policies from all over the world, and also consequences for the health workforce to take this forward. What's very interesting is how this response to what we call digital determinants has really been gathering speed. And in just a couple of weeks' time, the European Union digital ministers are coming together in a meeting, and they are working on a new concept, an EU-wide concept of digital adulthood, and wanting to put a limit on access either to certain platforms and possibly even devices until a certain age. And usually that age is defined in terms of adolescent development steps around 15, 16 years of age. And we will see probably in Europe, just as with the other policy initiatives, the GDPR and others that you've heard about earlier today, that Europe wants to take the lead in creating safer digital environments for people, for taking a special focus on young people, and for taking the precautionary principles that Europe is known for. Thank you.
Thank you very much for this insightful presentation. We will dig the topic a bit deeper with our first panel of the session on digital health for youth mental health. So for this panel, I'd like to welcome on stage Sophia Achab from Geneva Youth University Hospital, psychiatrist specialized in the management of behavioral addictions, as well as Matthew Brown from Wellcome Trust, Head of Digital Technology Discovery Research in Mental Health for the Wellcome Trust Foundation. Brian Lee-Han Wong from Adagio VR. Brian is a Global Public Health and Research Director for Adagio VR. And to moderate this discussion, I have the pleasure to welcome on stage Patty Michel from Health Enabled. Patty is the co-founder and CEO at Health Enabled, a global nonprofit advancing whole person health through equity-focused technology. Thank you.
Okay. So wonderful to be here. Just want to express my appreciation to the Geneva Digital Health Lab for having us, for hosting this incredible program today, and to Ilana and Alain for setting the stage for what we're going to talk about on this moderated panel. So the digital determinants of health, it's sort of like a full circle moment for me in my career in global public health. I did my PhD on health-related uses of mobile phones in Egypt in 2002, 2003. And so it's amazing to see kind of how far the field has come since that time. But now we're kind of going back to almost the beginning again to think about, okay, how is technology impacting everyday lives, and in particular, young people's everyday lives. So young people are now growing up with devices in their hands, and need to now find ways to make sense of how to better leverage those devices that are in their hands. And I'm really excited to have joining me for this panel, Matthew, Brian, and Sophie. And so maybe what we'll do is maybe just so that everybody gets to know who you are and what you're doing in terms of youth mental health. If you could just give sort of like a 1 or 2 sentence introduction into who you are and what you're doing in this particular area.
Thanks, Patty. Great to be here and great to follow so many mentors of mine and colleagues in the digital health space. My name's Brian Wong. Like many in the global health space, I wear a lot of hats. Of them, I would say I'm a health diplomat, a global health strategist, and a health advisor for health tech startups. And what we do at Adagio VR, where I serve as the Global Public Health and Research Director, is we use immersive, culturally grounded mental health interventions delivered through VR to really support the mental health in communities that are marginalized, both at present in the UK as well as in India.
Great, thanks. Yeah, also a pleasure to be here. So I'm Matthew Brown. I work at the Wellcome Trust. So we're a private philanthropy. We're based on the Euston Road in England, in London, but we do fund globally. And our strategy is really centered around 3 health challenges, one of which is mental health. And so we're really looking to create a step change in our understanding and treatments of anxiety, depression, psychosis. And I think, you know, while the digital environment offers real challenges, it also offers real opportunities for mental health and a clear route to engaging with people who need those interventions. And so what we are looking to do is to sort of see where the optimism lies, see where the research leads us, and where we can support really effective, innovative digital mental health interventions.
Thank you very much. I'm Sophia Shab. I'm a psychiatrist by training, addiction specialist, and working in this area of mental health and digital since 20 years now, from different perspectives. First of all, research, then clinical, then public health, and then trying to develop the more fit for purpose response, treatment response for harms related to digital use. But we are not at the facility that I run since now 27. It's the pioneer one in Switzerland dealing with the tech use disorders, called tech use disorders. But we are not digitally free because digital tools are part of our treatment offer, and part as well, very crucial part of our assessment. So maybe this sets the stage of my willingness always to be in balance between the opportunities and health risk of digital. Thank you.
Great. And I think what's important to note is that mental health was probably one of the first use cases in which digital technologies really took off, and where some of the evidence started to build, which I think is, so now to see some of the more advanced approaches that you all are exploring and working with, I think is really interesting. And so maybe, you know, if I can, you know, point it to you, Matthew, to maybe share a little bit about sort of like the landscape of the sorts of things that you guys are like researching, what you're finding, where you're seeing the innovation kind of going. And then we'll have Brian and Sophia kind of share what that looks like in practice.
Yeah, thanks, absolutely. So I think as a funder, a global funder, we see some really sort of interesting and innovative approaches, and it goes all the way through the pipeline. So you see everything from kind of productivity increases within healthcare settings that are mental health refined, all the way to sort of targeted apps and interventions. One
nice one that we've been a long time funder is the Avatar Avatar intervention, which is essentially a digitally enabled therapy that we funded trials of in the UK, and it provides essentially a digital avatar of people's auditory hallucinations. And by doing that, by embodying that auditory hallucination, you actually reduce the feelings of anxiety those individuals are suffering. So we've seen that and many other interventions. And I think now the main thrust is we're starting to see a lot of the evidence come to fruition. And now we want to start seeing the impact of those interventions in the people that need them. So we've just funded, had a recent funding call on scaling digital mental health interventions. We've got an accelerator and then another funding call on looking at the research behind large language models, how you can refine and use those in the context of mental health. And so we're just very excited about seeing where they take us.
Great. Maybe I'll turn it over to you, Sophia, to kind of talk a little bit, so what does that look like in practice? Like, how are you seeing the application of these different, approaches?
Yes, in practice, I will give 2 examples. One of the examples is how we do use digital in our assessment. When we have parents coming with yours, and they are just there with you in your at your University Hospitals of Geneva facility, asking for help regarding to digital tools and the excessive use, such so-called excessive use of digital tools. And they are very surprised to find us in our assessment and from the very beginning in willing to engage in communication between parents and yours around digital in a positive way as well. Positive way, just explaining what are the purposeful, for example, limits in terms of time, in terms of, is it purposeful to put it in time in terms of hours of use, or respecting, for example, the sleep or the food intake or the moments, how to set limits. And we work with parents around how to set the limits. The second thing that we do in our assessment phase with those youth is to use their digital materials and what they do on those digital platforms to understand better who they are, what they do, what are their psychological needs in their digital activity, and mainly they can come to us, and I ask them to come with some digital materials such as on a USB stick, or to come to my consultation with any kind of material that they would like to share, just for me to understand better what they do on those digital platforms, who they are in their digital lives, and what kind of engagement they have with others on those digital platforms. So it is really a part of our digital, of our assessment, and it is part of our treatment as well. We do propose telemedicine. Using our platform, UG at Home, which is University Hospitals of Geneva at Home. It's a platform that we have in the hospital, and that we use very often to deliver care to people if they are willing to engage with us in that way. It should be a feeling a care need and really making sense, both for the caregiver and for the patient.
Great. No, thank you for that. And maybe like Brian, maybe you can share, kind of like what, VR is doing in some of the work that you're doing and what you're finding, some of the benefits are of the approach you're taking.
Yeah, thanks, Patty. So what we do is we deliver, as I mentioned, a stack of digital mental health interventions through VR, and what we have is a nonverbal, culturally specific intervention that is really tailored to the needs of the communities that we work in, which, as mentioned, are marginalized populations. I think just maybe a quick reflection, kind of based on what we've heard as well earlier today, is and from our experiences, is that really, like, effectiveness without equity is quite hollow. I mean, I think a tool can be clinically validated. You can have as many pilots as you want, but that doesn't necessarily consider who can actually access it, and whether it reflects kind of the user's identities or their needs. So what we do at Adagio VR is we really kind of prioritize three things to bridge those gaps. The first is around localization, not just when it comes to the language, but also, emotional and cultural relevance, so that, what feels like it's calming or safe, it really differs across communities, whether it's in the UK or in India. The second is really around layered support, and we really like to pair our tech with that human touch, and you hear a lot about kind of human in the loop. And what we do is we train, peer mentors, we train community health workers who are trusted individuals in those settings to really deliver that intervention so that the experience isn't isolating. And then the third one is around lived experience, and we've heard quite a bit about that earlier today. But we really like to involve young people, particularly those from the LGBTQIA plus communities and marginalized youth, not just in feedback, but also in shaping the tools that we're actually delivering. And that's, I think, how we ensure that AI or VR or other techs don't really replicate biases of existing systems, but start to build trust, like we've heard earlier today.
Great. So quick question to the audience. How many of you have a young person at home that is, under 18? Okay. And how many of you would feel like their sort of adoption and use of digital technology is improving their social, mental, and physical well-being? Nobody. No, I mean, as Ilana pointed out, I mean, there have been a lot of studies, and I think I'm encouraged by the growing evidence in this area that there are incredible benefits, I think, to young people's social, mental, and physical well-being. There are also, harms to those things, as well. And I think we need, a lot more, I think, education in terms of how do we, harness the benefits while mitigating, some of the key risks alongside some of the policy, advancements that are coming our way. And maybe, Sophia, like, where have you kind of seen some of the benefits of using digital or even technology in everyday life as a beneficial part of youth mental health, and then how are you and what are you seeing in terms of some of the negative effects and how you're addressing those?
Thank you very much for raising this question of the how to achieve the balance and how to take the good and to avoid the bad. It's very, very hard. It's a complex exercise. Positive things from digital for youth, many, because they usually interact through those platforms. They are really engaged, including emotionally and psychologically on those platforms. It's not something which is not for real for them. It's real interaction and real engagement in those platforms. They do share real things and very deep things in their intimacy and their feelings on those platforms. It's very fulfilling for them in many ways. It can be leisure activity, it can be connectedness, it can be a sense of belonging, it can be as well feeling that you can share discourse or information about what is going on those digital platforms in a daily basis with peers. It fulfills the very different needs, and I can see it in my practice as well. It can serve therapeutic purposes. For example, when we do have a social anxiety, for example, in youth, and we working with them on what they do on digital platforms, how they interact with others on those digital platforms, and just capturing the skills, the interpersonal skills that are there, but they are digitally performed, and just helping those youth to copy paste in the reality what skills they have on digital worlds. Negative things about the use of digital in youth, so feeling of loneliness sometimes, bullying, data protection, problems of sleeping, problems of attention, being able to focus long task, or to be able to, for food intake as well, for sedentarity, physical activity, can be in many ways. But we should really take maybe I always give the example of the knife, the kitchen knife. You can use it to make a very, very tasty plate for the family, but you can use it at the same way to just harm others with this knife. And it depends on the intention, it depends on the tool, it depends on how you are intending to use it and how you are using it. I would say what from those positive and negative things I would recommend is to really be focusing on how it doesn't matter age or number of hours. Maybe one main principle that we should keep in mind is, I developed it years ago when I was repeatedly asked by media and parents, how many hours should they spend on online platform? So it is not about hours, it's about really run your devices and don't let them run you.
No, I think that's a really great point. And we're sort of in our wind down of our panel discussion. And so thank you for that recommendation. Would love to have Matthew maybe share, what some of the recommendations that are coming out of some of the research that you're doing would be great.
Yeah, sure. Yeah, so we're still, at a fairly early stage, so we're funded the recent teams scaling digital intervention. So we're going to be waiting for the readout of those in a couple of years. Likewise for the generative AI work. There are some themes that always come across strongly. So context, specificity and relevance is a key one. I think, generic solutions just won't cut it. And you need to be able to, especially in a world when you're talking about AI-enabled digital interventions, we know that these algorithms do not translate and transfer well across context cultures. So context relevance is absolutely key. I would also say getting the right metrics. I think too long people have been using kind of recruitment and retention, like number of clicks on the app, how long do people spend on their devices, as a proxy for whether or not your intervention is working. And that's not what any of us want to measure. You want to measure the actual outcomes that we care about: symptom improvement, functioning improvement. So I think there are some key ones, but really, as a funder of research, we say we need more evidence, so we need it at scale in the right places.
Great. And then Brian, what are some of the recommendations that you have from some of the learnings that you're getting from the work that you're doing?
Yeah, sure. I think one of the biggest ones is that, digital tools really will fall short if they're built around assumptions, around what, the end users want, around how they behave, or what mental health might look like in their context. And we've heard a lot about kind of contextual relevance. I think, that the tech might work fine, but it won't necessarily land or stick if it doesn't speak to the people who it's meant to reach. And I think you'll hear from our founder, Sonia, who's in the room later during the FailFest, about kind of how we've learned the hard way that even, the most sophisticated intervention will miss the mark if it's not trusted, if it's not relatable, or if it's not grounded in the lived reality of the people that we're trying to help. And I think since then, and again, you'll also hear we've shifted our model to kind of really be co-created. We co-create every rollout with young people, with the community health workers, with local organizations to really ensure cultural relevance and buy-in, and that's how you start building trust.
So I really just want to thank all of you for your attention, and then also for your insights. I think it's just really, really becoming more and more important that, Sophia, to your point, that we engage young people to become, masters of technology and not have the technology kind of master them. So I just want to have a round of applause for our panelists, and thank you for the work that you're doing. And the impact that it's having, and hand it back to our event organizers.
Thanks, Barry. This was fantastic. I wish I could get my 5-year-old to listen to all of this. I'm supposed to do a quick check of how focused the audience is, but I see everybody's eyes is focused on the stage. So fantastic. I don't think we need an exercise to get you woken up. But a big round of applause for everybody for being so focused and being so engaged. Thank you for that. Now I have the pleasure to welcome Dr. Frederick Erra, Strategic Lead for Patient-Centered Digital Health at Geneva University Hospital. So he is coming with the next pitch on Infomed, the digital compass for navigating urgent care. Welcome.
Thank you for the presentation. So I don't pretend that I will refine the late schedule, but I will try to go as fast as possible. So yeah, if I manage that, yeah. So Infomed, that's an application helping patients to find a good care response regarding the patient situation. So I think any of you have been already confronted to a situation where you have a problem, you hurt yourself, you have headache, you have backache, and you don't know really what is the proper response to this situation. Should I go to the emergency? Can I wait to see my general practitioner? Can I just self-care at home? Though that's what Infomed, an application that we have developed at the University Hospital of Geneva, attempt to reply. So it provides advice based on symptoms that you enter into the application. We saw this morning other type of solutions such as Ada Health, but this solution is very strongly integrated with the hospital and helps to improve the patient journey all along. So there is 3 key pillars in this solution. So as I said, there is a symptom-based self-assessment where you report some symptoms that guide you. But you have also a view on the real-time emergency department data. So it means that you know whether it's the good time to go to the emergency, whether there is a lot of people, or if you could choose another option. And obviously there is a strong effort that has been given to provide human-centered and fully designed interface, because that's always something that needs to be easy to use by any kind of patient, even though the one with the lower digital literacy. So view screen of the application. So you can see, you can see there. So there are different centers in Geneva that are integrated. So you can see whether there are a lot of people already waiting. After that, you can choose where your problem is located. And at the end, you receive an advice whether you should go to the emergency or not. And when you announce that you go to the emergency is warned that you arrive and can prepare everything accordingly. So the impact, there is over 60,000 users in its launch. It's deployed in pediatric, adults, and geriatric emergency. So we still need to do formal evaluation, but that's something pretty complicated to do, but we are working on that. But what we know is that it's really improved the patient experience, and hopefully it reduced the pressure on emergency service, which is very strong nowadays. So next step will be to scale the solution, to integrate it more strongly into the regional platform and maybe beyond, and also to work on this evaluation that will really prove the benefit of the solution, the situation. Thank you.
Thank you very much, Frédéric. Our next speaker is Martin Jacobs. Martin Jacobs is working for many years at Humanity and Inclusion on rehabilitation and innovation, and he will present today Open Telerehab. Thank you very much, Martin.
Thank you. Good afternoon. First of all, thank you very much to the GD Hub for organizing this event and allowing HI to present a little bit of the work that we are doing in the field of digital rehabilitation. My name is Martin Jacobs. I'm working as Rehabilitation and Innovation Policy Development Officer for HI. And today I'll be presenting you a little bit of the work and the solution called Open Telerehab, which is a digital public good aiming at improving access to rehabilitation services globally. But before talking about a solution, let's maybe have an overview of the problem. So it was mentioned earlier, 2.6 billion people globally are living with a health condition that may benefit from rehabilitation. So this is 1 in 3 people globally. So you can imagine the magnitude of the needs for rehabilitation services. And in some countries, and especially in countries HI is working in, low and middle income countries and emergency settings, more than 50% of people do not receive the rehabilitation services they require. This is obviously linked to many different factors. One of them being the fact that rehabilitation intervention is a long-term intervention. Imagine yourself with an amputation, imagine yourself survivor of a stroke, imagine a child with a cerebral palsy. This will require a long-term intervention. So this is the problem that we face. And then obviously there are always opportunities. I won't, well, extend myself on the opportunity coming from the information and communication technologies. I guess most of the people in the room know that already. I think one of the opportunities specific for the sector of rehabilitation is that most of these services can be provided remotely. And this is very unique to rehabilitation sector. We don't need to provide a drug. We don't need to get a blood sample. And we can provide many different services remotely without face-to-face intervention. So the solution that HI has developed and co-developed is called Open Telerehab. It's aiming at expanding access to rehabilitation services in low and middle income countries. It's an open source, multidisciplinary telerehabilitation platform. So it's designed for physiotherapists, occupational therapists, speech and language therapists, orthotics and prosthetics. And it's basically connecting professionals and patients to enable better care transitions, follow-up and continuity of rehabilitation services, and hopefully in the future, identification and referral at primary healthcare level. We really see this and have developed this as a complementary solution to traditional rehabilitation service provision, so as to strengthen health systems and contribute to universal health coverage. Some of the key features, obviously our name is Humanity and Inclusion, so we focus a lot on inclusion and accessibility. So the software is available online, offline. It's available in multiple languages with built-in translation features. It's available it's an early adopter of the WHO ITU global standards of telehealth services. The software is also data-driven. Obviously, we are FHIR compliant, so interoperability is a core component. We leverage business intelligence, and we have built-in survey features. And then finally, it's scalable by design in a way that it's, again, leveraging open source technologies. It's microservice architecture so as to be easily localized and transferred to the relevant bodies in the countries we work in and for. And then I wanted to finish off with this slide. It's quite dense. I'm afraid it's already late in the afternoon, but it's providing us, a vision of what we try to achieve here. And what we want to do is improving high quality rehabilitation services for marginalized communities through an inclusive and scalable service delivery model that includes telerehabilitation, but not only. So we work with and for health professionals to empower them. We provide them capacity building. We work with and for marginalized community to deliver rehabilitation services, including with telerehabilitation platform. We work with and for national authorities to demonstrate, collect data, and demonstrate the effectiveness of everything we try to do. And then, and I realize the slide has a few mistakes there, but anyway, and we work on scaling together with national authorities. So if you want to partner on this with us, feel free to get in touch with me. I have no QR code, but I guess I'm tall enough you'll be able to see me. Thank you very much.
Thank you very much, Martin, for the presentation. For our next solution pitches, we'll welcome on stage Felix Gerber, MD and PhD candidate at University Hospital of Basel. Felix will talk about clinical decision support for community-based hypertension and diabetes care in rural Lesotho. Thank you, Felix.
Thank you very much, and a warm welcome, everybody. So today we're going to talk about healthcare delivery in Lesotho. So here you see a typical landscape of Lesotho, a small country in Southern Africa. You can imagine that while this is a beautiful view, living there comes with some difficulties regarding accessing healthcare services. One potential solution could be the involvement of community health workers. Many countries have existing community health worker systems that we could build upon. However, over the last decades, they have mostly focused on infectious diseases such as HIV or maternal and child health conditions. Now, we have an ongoing epidemiological transition, aging populations and increasing burden of chronic diseases such as hypertension or diabetes. And there is an urgent need to now develop innovative solutions to include services for these conditions in community-based healthcare delivery models. And this is exactly what this project was all about. So in 103 randomly selected villages in Lesotho, such as this one, community health workers were elected by the local populations. They were trained in blood glucose measurements, blood pressure measurements, and most importantly, equipped with the clinical decision support and data collection application. So here, the basic setup. One community health worker per village with an application based on the open source and interoperable community health toolkit. Now, if we want to drive innovation in healthcare, what we usually need are randomized trials. So in our case, half of the villages were assigned to the control arm, where community health worker provided services according to the currently available evidence. This includes blood pressure screening and diagnosis, the same for diabetes, then lifestyle counseling and referral to a healthcare facility for drug prescription by a professional. And here now you can see the weak link of the current approach. If you imagine being an elderly person with hypertension or diabetes, not having any symptoms, and being told to travel to a facility regularly for checkups and to fetch your medication, this is quite difficult. And on the other hand, we also know that healthcare professionals are already overburdened now. So how will they cope with the increasing numbers of patients requiring chronic care? Now here comes our idea. We have now digital tools for algorithmic guidance and remote supervision. And we could use this to bring community-based chronic care to a next level. So in our intervention arm, community health worker, in addition to the screening and diagnosis services provided in control villages, were also guided by the clinical decision support application to independently prescribe first-line pharmacological treatment for hypertension and diabetes, and to conduct a cardiovascular risk assessment for the prescription of statin and aspirin. Now here, just some key findings. Overall, more than 16,000 participants were enrolled in the overarching cohort study. Of those, more than 98% were screened for hypertension or diabetes through repeated home visits by the community health workers, which is a coverage that you could never achieve by just providing these services at the facility. More than 1,500 people with hypertension or diabetes were identified and enrolled in nested randomized trials. And here now, the first key message of the day. Over the course of 1 year, community health workers supported by clinical decision support were able to independently manage more than 80% of the people with hypertension or diabetes at the community level without them ever needing to travel to a health facility for checkups or medication refills, thereby not only alleviating the burden on the healthcare professionals, but also getting rid of the most important access barriers. Now, improving access to care is one thing, but improving health outcomes is the other thing. So here, just as an example, you see the results of our blood pressure trial. In purple, control villages, so screening, diagnosing, and then referring. You see, this already led to a quite significant decrease in systolic blood pressure of about 15 mmHg. But now if you look at the intervention villages where lay community health worker provided medication and not healthcare professionals, you can see that the blood pressure decreased even further with a significant difference at 12 months. And let us just keep in mind that simple interventions, such as blood pressure reduction, are still the most effective interventions that we can offer to reduce overall mortality at the population level. So these findings clearly support the involvement of community health workers, supported by suitable clinical decision support tools, not only for screening and diagnosis, but also for the first-line pharmacological management for major chronic conditions such as hypertension and diabetes. Thank you very much.
Thank you, Felix. Now I have the pleasure to welcome Dr. Mirana Michel, Chief Technology Officer at Geneva Digital Health Hub, GDHB, and Scientific Collaborator at the University of Geneva. She'll be speaking about the Digital Health Atlas, which you have all heard about, now a little bit deeper. Welcome, Mirana.
Thank you, Canon. Digital health tools hold tremendous promises. It's not a secret for us anymore. Around the world, there are valuable digital health projects that are transforming healthcare. We've seen a lot of them today. But too often, these efforts work in silos, struggle to scale, and valuable lessons are lost. There is no shortage of information, but we are drowning in it, not learning from it. What if there is a better way to capture, organize, analyze, and extract insight from all these knowledges? What if we could make this information digestible, actionable, and science-based to guide smarter decisions? That's exactly the mission of the Implementum, to turn real-world digital health implementation data into insightful and science-based information that support better policy and implementation decisions. To do this, we've developed a suite of toolboxes with different partners to capture knowledge from both implemented projects and scientific researches. One of our core tools is the Digital Health Atlas that Professor Labrique mentioned earlier. It's a global knowledge base of digital health project, originally launched by WHO, but we've worked to enhance it for easier collection, navigation, and use of digital health information. However, having information is not enough to transform the data into knowledge. We've developed a digital health AI assistant, a conversational interface that helps users interact seamlessly with the data. So for example, as a policymaker or person working at the ministry, I can understand digital health landscape in my country at a glance. Here, for example, in Senegal. Another use case could be that as an implementer, I can explore existing projects, identify challenges, and learn from best practices. For instance, here, for example, I'm asking about telehealth. So I can ask what lessons could I learn, what challenges have other implementers faced, so that I try to avoid it when I'm trying my implementation. If I am interested in a specific field, for example, in decision support, I can ask about specific project on this decision support, and I can ask the assistant to summarize to me the key important areas that they should know about the project. What are the similarities between the project? What are the differences between the project? What can I learn from this if I want to work in this domain? And at last, we have one last use case. It's a funder. If I am a funder, and that I want to track, for example, my portfolio to identify priority areas and spot gaps where most investment is needed. For example, here, I'm trying to understand which projects have been funded by the Botnar Foundation,
And what are they focusing on? Are they focusing on what type of services, what type of target population? Where are the gaps? So these are just examples. We are at the beginning, and our goal is to provide context-aware insight by country, by topic, by funder, to support evidence-informed policymaking, to guide future implementers step by step, and advance the science of implementation. But we cannot do it alone. This is a collective effort. We need your experiences, your insights, and your project. Together, we can turn digital health implementation knowledge into global public good. We invite you to join us, contribute to this shared effort, and help shape the future of digital health. Thank you very much.
Thank you very much, Mirana. We also have a booth next to the coffee if you want to pass by during the next break. Now we move to the second panel, very important topic on financing constraints as a catalyst for change. So please welcome our panelists. We have Jérôme Mas, that you all know now, Director Access to Care at Philips. We have Dr. Nada Malou, founder of Antibiogo, working at Doctors Without Borders. Please, Nada, I don't see you. Steve Ollis, Senior Technical Advisor for Data and Information System at WIMA International. Peter Speyer from the Novartis Foundation. Dicky Settle, Interim CEO, please come with me at Medic. And to moderate this panel, please welcome also Caroline Perrin, Director at Gilead.
Good afternoon, everyone. Not an easy task to come after so many excellent speakers and in the middle of the afternoon session, but with this set of energized speakers and insights, I'm sure it's no problem to follow. So most of us work in digital health since a long time, and we all know that sustainability has always been a major challenge in digital health. And honestly, the current situation and funding constraints are not helping with that. So maybe this is also a moment to rethink if we need to adapt the models that we have been following. So it's a privilege to be joined by a panel of experts from different expertise, private sector, humanitarian, government, community level, and so on. Nada, last year you were at Geneva Digital Health Day and you presented Antibiogo. And your work has really shown how innovation does not stop at development, but must extend through regulation, quality, and long-term viability. So how has financial pressure shaped getting a digital health tool certified? And what does sustainability really require when regulation is part of the equation?
Thank you very much, Caroline. So it's a broad question. I'm not sure that I'm going to be able to respond within a few minutes, but I think it's important to say that the problem with the sustainability of the funding for digital health tool is prior the situation that we are experiencing today, because as you know, today the majority of digital health tools that involve clinical decision are classified as software as medical device, which means that there are a lot of constraints regarding their initiation, development, validation, but also implementation. And I don't know how it arrived, but as you know, Médecins Sans Frontières, we are a humanitarian organization, so usually we intervene to provide care for population. And we ended up becoming a legal manufacturer of a software as medical device. The first software as medical device that is CE marked by an NGO, and that was developed by, with, and for LMIC. An important also point in our experience is that this tool is a diagnostic tool that is provided for free for LMIC, which complicates the question of the sustainability of the model, because the model by itself is an innovation for us. And so I think it's important to today on Chibayogo, so it's not anymore a project, it's a diagnostic tool that is used in more than 20 countries by Ministry of Health. And we are really in this time of transitioning from the innovation to a tool that is part of the diagnostic pathway, the patient pathway. And so this is the most challenging transition in terms of funding, because in terms of implementation, from our experience, that's the scale up is not the most challenging in terms of funding, but it's the maintenance of the tool. And the maintenance is like not very sexy. Nobody wants to fund maintenance. What is sexy is research and development, is implementation, is to say, okay, we're in this country and in this country. But for software as medical device, it is not possible to sustain those tools if we are not able to have specific funding for maintenance. And so this is the experience that we will be discussing, and I will try to share with you in order also to have this call for funders about the need to change the mindset about how we think about funding. And Professor Labrique said it, like we need to stop thinking about funding as a project, but like for the whole life of the software and the diagnostic test in the case of Antiviral, for example.
Thank you. Thank you very much for highlighting this invisible but critical cost of maintenance. Dicky, you've seen digital health from almost every angle, you know, at national level to the last mile delivery. Based on your experience, what do you think is missing from how we approach sustainability models today?
Thank you very much, Carol. Hi, everybody. One thing that had been really endemic in the historical funding, and a challenge I've been personally trying to solve for the last 20 years, is that sustainability of the DPG platforms, right? And what the historical model has really looked like is that the DPGs really had to get engaged in implementation. The digital public goods needed to get engaged in implementation because that's where the funding was, and would subsidize the work to support that digital public good through doing implementation. Now, that really doesn't really offer the strength of a DPG, in that by doing implementations, you end up competing with the very community you want to support the DPG. And so there's some misaligned incentives there that also reduce the opportunity to really lean into the local implementation capabilities, the local support capabilities, local sustainability capabilities. And so I think now, as we're seeing a big shift in how these contributions are made, if we can work together to find ways to support DPGs to actively not be directly involved in implementation. Often DPGs, I think, get asked, what are you, a product organization, an implementation organization? And I think we can really support them to be capacity strengthening organizations, where the tools, the communities are really about advancing autonomy, capacity, and ownership at all levels. That's where we're going to see some success. I have one example. One country that MEDIC has been very active in had a really substantial challenge with the recent shifts. So major projects by bilateral donor shall not be named, but you can all guess, ended suddenly a few months ago. And very shortly after, the entire data center shut down, and there was no capacity or capability to get it back up for 2 months. And we're talking the DHIS2, the National Community Health Information System, huge platforms that large numbers of people were dependent on. And no one knew there was this dependency on these projects that would historically ride in with funding and technical capacity and get that stood back up. And in the absence, there was no one who could do that. And so it was 2 months of effort to really get the data center, the systems transition to a right place. And still, I don't think the sustainability funding for that hosting is clear. But it is a very clear example of the challenges of the historical models, but the opportunities we have to really lean into and ensure we don't replicate that again.
Thank you, Dicky. That call to rethink development models feels really timely. Peter, last year we heard from Anne about the amazing work of the Novartis Foundation and how Cardio4Cities shows how data can drive measurable results in urban health. So from your perspective, how can the better use of data support the case for sustainable financing and guiding more impactful investment?
Thank you. Excellent question. Hi, everybody. So I work for the Novartis Foundation, which is a non-profit organization funded by Novartis, but arm's length, drug agnostic mission to improve population health. Cardio for Cities is a program that aims at controlling cardiovascular risk factors. So we go into cities around the world and we're trying to find people that have hypertension, diabetes, or high cholesterol, and make sure they get treated, diagnosed, treated, and controlled to avoid events like heart attacks and strokes. And so data plays a key role on many levels here, right? We can use data to help find people, the most vulnerable populations. Where do we screen? Where do we intervene? We can use data to engage patients better, from adherence to kind of disease management. And we can use data to evaluate, is this actually working and how can we do our job better? I think the key challenge and the key insight that we're leveraging in cardio is you cannot build this as a separate system. Like Dicky just said, right? You build a system for a project, funding runs out, the system stops. So from the beginning, we involve the city government, we involve civil society and the healthcare system to make sure we have a broad-based buy-in, and we build this project into the infrastructure from the beginning. And so we have the benefits of using better and better data, but we're building it such that it can be maintained in the long run.
Thank you, Peter. I think, reminding us of how the power of data can make the investment case is really important. Steve, you've worked across scales from community nurses to national systems. How are the current financing challenges impacting the field?
Yeah, and I think I wanted to touch on a couple of points. I think the point that Nada raised earlier about, people want to fund innovation. I think one of the things that needs to shift, that I hope will continue to shift, is yes, innovation is good, and I'll talk about the number of innovations we introduced, but what if we actually started counting the number of existing systems that we leveraged, quantifying the collaboration and showing that instead of bringing in a new innovation, we strengthened an existing innovation, we expanded an innovation. And I think that that's a real shift. I think some of the experience that we had working for a project that shall not be named, but again, where you have funders who come in within an individual funder coming in with different vertical funding streams, being matched up in a country where you have a Ministry of Health that then has their own programmatic funding streams and their executions. So what often we would do is you have an example of, okay, I want a malaria database to track my malaria cases. Great. All right. So one of the things you needed to have was, again, strong governance practices. You need to have a strong digital vision, a strong HIS committee to actually start bringing people together, but then also to be able to show, and ask, why do you want this data? Why do you want your own system? Oh, well, I know it's collected in this other system, but we don't get the data on time, or it's not of good quality. So we would work to then try to address those shortcomings and say, can we work to address those shortcomings, but doing this in the national system that already exists rather than building your own separate system? And so there you had to make some short-term trade-offs, but ultimately you're strengthening the system. So I think we were able to do that in a few cases, but it involves really sitting down and having the conversations to say, I know you had in your work plan that you were going to introduce a new system, and maybe even the funder had said we were going to introduce a new system, but say, look, you're going to get better data, you're going to be strengthening the national system, let's come together to align and let's count that. And sometimes those were difficult discussions, but I think the more that we have those, the more that we can continue to really maximize the results that we can get with these diminishing resources.
Thank you, Steve. Jeroen, you've been involved in building. Sorry.
Still here.
Yeah, we're too close. So you've been involved in building partnerships across sectors. What have you seen that actually works in partnership?
Yeah, thanks, Caroline. I jotted some things down, otherwise I talk too long because it's such an extremely interesting field, but we're much aligned. So these last days we heard a lot, like you said, Nikki, it's a challenging time, but healthcare has always been resource scarce or resource poor. I mean, and yet we always had time for, like you indicated, sexy research, like pilots, like newspaper clippings, like, hey, we're all there. And we all did that. It's private sector, it's NGOs, governments. So that was one of the goals of when we started DCCC in 2019, to get rid of that one-off point solution type of interventions and get rid of the transactional stuff like I pay you, you give me something. I mean, it's okay if I get an ice cream here in Geneva, but it's not okay if you want to maintain your tool in the long term. Then we need to really look into systemic interventions, relationships a lot more. So that's what we really started out doing. And that meant pooling resources, private sector resources, NGO resources, sometimes even government resources, and bring them together and really leverage them. And maybe to start with pooling, 2 points. Pooling is needed on two ends, say in developing, like you really eloquently indicate, developing a tool. There you need financing or pooling resources to get it done. But to maintain it, to get it out into the field and to really have a lasting impact on people's lives, that's where we need it most. That's where where most money is needed and longest is needed. And finance definitely has a role to play. Absolutely, but it's more than that. It's also bringing in the capabilities of all these organizations involved. Like if you work with AXA, it's not just Michal, who we will see on stage later, that we bring in, but also his 15,000 colleagues. We can leverage that. It's not just the money, it's also the capabilities, the insights, the networks. Having said that, there is a really nice example of pooling resources for a financial tool, like blended finance. I won't go into the detail, but there is a fund. It's called Transform Health Fund, where private sector donors, philanthropists came together and pooled 111 million that is being used to scale digital health interventions, not to build new ones, really to help people. And it's, if anyone interested in details, I'll be happy to explain more later. But I also want to highlight two other examples. So one is the DCCC project that we're doing in Nigeria, but Michal and Charlotte are still here, where AXA, Farm Access are pooling resources with a local organization called Drugstock to deploy digital solutions and really make sure there's more primary healthcare delivery. And we did the same in India with PATH, your former sister organization. Many Indian private sector parties, a funder, Philips was involved, many other organizations, to improve and bring new technologies into the existing, like you indicated, the existing Ayushman Bharat system. And that worked. It worked so well that it's being copied by Indian state governments into other states at the moment. So pooling resources really works, and I think I'll save my learnings for the end.
Okay. So you already elaborated on what financing models you think actually encourage innovation, and this pool-based is a great example of not only encouraging innovation but also, bringing it to scale. Yeah. Is there anyone who wants to add something to that? No. Okay. So. Yeah.
I mean, that and pooled funding was one of them, right? And we had a nice chat right before here. I said, yeah, I like private partnerships. He said, no, I hate that. I said, why? He says, that means private funds. Oh, okay. Well, what do you prefer? Is transformative partnerships. Love it. I would say another thing I've been really interested in recently is this emerging triple P of public-private philanthropic partnerships, where by its nature, it's not just private funding, but finding how do you bring all kinds of funding together into innovation. So that one's pretty cool. I have more middle stuff.
I completely concur with that. I think we need to think about when we use which of the P's, right? If you want to start up something completely new, I think it's totally okay to dip into philanthropic funding and have one-off funding and say, we need to try if this works at all. But as you then think, about scaling up, I think that's when you start to hit limits, what you can fund with just philanthropic money, and especially the sustainability piece, it cannot be maintained, right? And systems will be shut off. So I think if you think about projects more in a phased approach and saying what do you need for innovation, and at one point, do you really need to start thinking hard about what does this look like in 2, 3, 5 years, then the budget really needs to sit in operational budgets of system players. Otherwise, you will risk continuously that it gets shut down.
Yes, please.
If I can add something, I think involving Minister of Health from the beginning in the discussion is also a key step, and we are seeing it right now, at least with our experience in Médecins Sans Frontières, when we discussed with Minister of Health about like funding the implementation of the diagnostic tools by like being funded by the Minister of Health, we don't have challenges and difficulties to find such funding. So I think involving them from the beginning for the early phase of the development. So not only on the design questions, because of course, when a diagnostic tool or any tool is user-centric, they are involved, but in also the model and in how are we going to adapt the tool to the change of the health ecosystem. Because when you start developing your tool, it's not going to be the health ecosystem is going to be quite different 4 or 5 years later, and even more right now with what we are seeing as a kind of revolution, both with digital health, but also with the funding. So I think Ministry of Health play a key role in the future of those innovation and in their sustainability by being involved from the first day.
Thank you. Yeah, I think that's really interesting. And I think what many of you pointed to is really the fact that, you know, sustainability shouldn't be an afterthought, and also the business model behind it and how we can sustain it over the initial innovation and excitement. So yeah, sustainability by design in whatever form, you know, if it involves transformative partnership or public-private or donor-funded. Unfortunately, we are running out of time, so I will let each of you give a final statement, one key takeaway you would like to share with the audience, can be call to action, one challenge you want to highlight. Who wants to start?
I can start.
Okay, ladies first.
I know it's a bit disappointing. So we have a room of innovator. We are all innovator. And so we are saying that we need to stop doing new innovation, but work on what exists. But that's clearly the message for the funders, also in the criteria and the way that the funding are built. We need to stop focusing on those early phase, only on those early phase of research and development. And otherwise we are going to end up, and we are seeing it with thousands of tools that are going to be available for 2 or 3 years, and then that are going to collapse. And this financial crisis, like, ask us to be responsible as innovator, humanitarian organization, Ministry of Health, to be able to, let's say, rationalize those innovation and call the funders to focus on the sustainability, the maintenance, and the less sexy part of those type of innovation.
Thank you.
So I couldn't have said it more eloquently. The only thing where I maybe slightly disagree is where you said about innovation. I think it is the innovation we need to work on. It is the implementation innovation. So, and that's the biggest thing that we have coming to us. Maybe, and it requires at least 2 things, many more. But for now, what we found, if you define something where you want to go to, do not describe a tool or as the end of the project, describe the impact you want to make, because only then you unlock a potential and you can invite other people to take part of it. And maybe one last learning, it sounds fun, it is fun, but it's also incredibly difficult and it takes a long time, but you will get through it. And once you're through that lag period, it's fantastic.
Great. Perfect.
So in line with the discussion about sustainability of funding, I think key advice is to, from the beginning, kind of cast your net wide in terms of who you include, in terms of project planning, capturing the needs and figuring out where does this actually fit into the ecosystem, right? Whether that's the ministry or government or city government in general, whether that's the health system providers, payers that maybe need to use whatever innovation you're creating. That includes civil society and of course the patients, right? So make sure you have everybody on board and you get the voices heard early on to make sure you not only innovate right now, but you kind of think about what does this mean for everybody going forward.
Thank you.
I think since we're talking about financing, one of the things, and I've heard this quite a bit this week, is about kind of simplifying language and using common language. So I think often we're talking about financing, we're talking about funding, we're talking about costs. I think we need to shift that language to focus on return on investment. right? Because we're talking about scale. We're talking about bringing in ministries of finance and other funders who have to make tough decisions, who are going to be asking ministries of health tough decisions. So what we need to do is really be able to look at these, whether it's an innovation or scaling something that's there and saying, what is the return on investment? And thinking about it that way. So to do that, we also need to be really honest about the status quo, right? What is the cost of paper reporting systems? What is the cost of supervision that's done by driving around to all the health facilities rather than doing some of this remotely? What is the cost of a maternal, an emergency, an obstetric emergency? What does that cost? And saying that's what it costs today. If we are implementing these tools, we can reduce these things and showing this as a return on investment rather than just constantly thinking of these things at cost. And then we actually need to do those things that will make that return on investment be real, like doing away with the paper reporting systems rather than just layering electronic tools on top of these some of these existing things. So those are my words.
Thank you. Yeah, I think there was also this very interesting report from WHO on telehealth that showed for every dollar you invest, you will get a 19-fold return on investment. And I think quantifying these impacts and these return on investments is very important to give decision makers kind of the tools in the hands to, invest in health rather than see it as a cost center. So, Dicky?
Said earlier, now more than ever, as the entire ecosystem is evolving, we must prioritize autonomy, capacity, ownership at all levels to really ensure that things we do are going to last. We avoid the systemic dependencies that have been the historic legacy. And please, investors, partners, researchers, let us please, I just can't agree with every single person up here more. Let's please stop prioritizing investing in innovation. Sometimes we know what works. But it takes time. It takes time for systemic change. It takes time for scale. It takes time for the sustainability. Keep investing in realizing that time. Invest in that power of scale. Let, on occasion, the unsexy be the innovation. Because what really matters is the scale, sustainability, impact, and health for all in the digital age.
Thank you. I think there couldn't have been a more perfect ending. So thank you very much. And conversation to be continued in a coffee break.
Thank you.